Review article on oligometastasis fallacy or real deal. The multidisciplinary management of oligometastasis from colorectal cancer. A narrative review. Abstract. In the United States of America, almost 150,000 people are estimated to be diagnosed with colorectal cancer in 2020, and up to 35% of those are expected to present with oligometastatic disease. The term oligometastasis was first used in 1995. However, surgical literature describing liver resection for colorectal cancer dates back to the 1940s. 5-year survival rates of up to 42% with surgery alone for solitary lesions are reported. Modern trials have demonstrated median overall survival rates of over 80 months for patients with colorectal liver metastasis treated with perioperative chemotherapy. Colorectal liver metastases have accordingly been described as proof of concept for the oligometastatic theory. Keywords: radiofrequency ablation, RFA, liver resection, stereotactic ablative body radiotherapy, transarterial chemotherapy, TACE, selective internal radiotherapy, SIRT. In this review, we discuss management options for oligometastatic colorectal cancer, including an overview of surgical concepts, the current literature on local ablative techniques, including stereotactic ablative body radiotherapy, SABR, thermal ablation, selective internal radiotherapy, SIRT, transarterial chemoembolization, TACE, and systemic therapy as an adjunct to local treatment strategies. We discuss the role of modern imaging techniques in selecting suitable patients for radical treatment. We also outline the role of the oncology multidisciplinary team meeting, which has become a key component in the care management pathway to assure that the increasingly complex treatment strategies available are appropriately selected and combined for each individual patient. We review the available literature on the impact on quality of life that each treatment modality affords, recognizing the importance of embracing advances in medical technology whilst maintaining patient well-being in the center of focus. Introduction. Oligometastatic colorectal cancer, OCRS, is generally defined as up to 5 lesions in no more than 3 metastatic sites, which typically involve the liver, lung, peritoneum, lymph nodes, and ovary. The terms synchronous and metachronous are used respectively to define OCRS where metastases present within or beyond the first 6 months of the diagnosis of the primary. Almost 150,000 Americans will be diagnosed with CRC in 2020. Of those, 20% will present with metastatic disease, and a further 35% will develop metastatic disease after upfront treatment for localized disease. Whereas 5 to 35% of patients are expected to present with oligometastatic disease, less than 10% of patients with metastatic colorectal cancer, mCRC, will present with resectable disease. While some fields of oncology are focusing on de-escalation of treatment in lower risk tumors 5 and 6, the introduction of the oligometastatic paradigm has conversely led clinicians to study more radical strategies for disease states that traditionally were deemed suitable only for palliative management. Written into the concept of the oligometastatic state is the premise that curative treatment paradigms may result in long-term survival. The term oligometastasis was first used in 1995. However, surgical literature describing liver resection for colorectal cancer (CRC) dates back to 1940s, and 5-year survival rates of up to 42% with surgery alone for solitary lesions are reported. Colorectal liver metastases have accordingly been described as a proof of concept for the oligometastatic theory. In this narrative review, we will discuss management options for oligometastatic colorectal cancer, focusing on temporary treatment paradigms, including an overview of surgical concepts, the current literature on local ablative techniques, including SABR, SIRT, TACE, and the role of systemic therapy as an adjunct to local treatment strategies. We discuss the role of modern imaging techniques in selecting suitable patients for radical treatment. We also outline the role of the oncology multidisciplinary team meeting, which has become a key component in the care management pathway. We specifically discuss the available literature on the impact on quality of life of each reviewed therapy. Methods. A literature search was performed on January the 9th, 2020 in PubMed using the search terms colorectal and oligomet. Only papers in English and in humans only were included. Papers were considered regardless of year of publication. We present the following article in accordance with the narrative review reporting checklist available at the link. The role of the MDT. Given the complexity of decision-making, the manifold mani- mm, the the manifold therapeutic strategies and the subspecialty expertise required to appropriately manage OCRC treatment decisions require the input from a multidisciplinary team at tumor board meetings in specialist cancer centers. The ideal MDT includes colorectal, hepatobiliary, hepatobiliary, and thoracic surgeons. Surgeons. Thoracic surgeons, radiation, and medical oncologists, pathologists, diagnostic and interventional radiologists, and cancer nurse specialists. The MDT's role includes registering patients in local and national cancer registries, ensuring thorough initial diagnostic workup, guiding therapeutic decision making, identifying patients as eligible for appropriate clinical trials, and evaluated treatment response. 1.14. The first management decision is to deem whether patients have currently, potentially, or never resectable disease. If not resectable, then disease amenable to radical ablative treatment strategies can be identified, and the most suitable ablative strategy can be selected. Imaging. Reliable and timely identification of OCRC with multimodal imaging is essential. Following treatment, imaging is used to assess disease response using the RECIST criteria, RECIST criteria 15, and subsequently in conjunction with serum biomarkers, carcinogenic embryonic antigen CEA to herald early recurrence of disease to allow further radical treatment and maximize the window of therapeutic opportunity. Contrast enhanced CT is generally employed initially to image the whole body, chest, abdomen, and pelvis, plus or minus brain, because of its widespread availability and relatively low cost. Dual energy CT is being increasingly used as it can provide better image contrast. MRI is routinely used to image the liver and the brain as it offers superior soft tissue definition compared to CT. Compared to CT. Whole body MRI is available in some centers and has advantages over standard imaging pathways. Fluorodeoxyglucose positron emission tomography FDG-PET in combination with CT is recommended in expert consensus guidelines. 18. To stage colorectal oligometastatic disease. It improves patient selection for hepatic resection and reduces the number of futile laparotomies. Its main advantage is in detecting extrahepatic lesions occult on CT alone. 21. Beyond the traditional uses of imaging described above, novel imaging biomarkers to guide management of OCRC have been extremely researched. Radiology can provide prognostic information, such as the presence of vascular invasion, a fibrous capsule, and details of the tumor-liver interface. Functional imaging, perfusion, 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 e.g., perfusion CT, and dynamic contrast enhanced MRI, can reveal information about biomarkers associated with tumor angiogenesis 22 that correlate with outcome 23-24. These techniques are not yet standardly used in the clinical setting. Surgery. The widely agreed definition of resectable hepatic disease is where complete macroscopic resection is possible whilst maintaining sufficient functional liver volume. 25. Specialist hepatic surgical input is essential to decide which patients are technically resectable and will benefit from liver resection on the long term. Oncological or prognostic criteria include the number of lesions, the presence of extrahepatic disease, and the time interval between the development of primary and secondary tumors, although there are no internationally agreed guidelines. Hepatic resection is safe and effective in the management of colorectal of liver metastasis, CR/CLM, and 5-year survival rates of 30 to 50% can be expected. Despite its long-established efficacy, there are no randomized trials comparing it to other treatment modalities, yet it remains the gold standard treatment where technically and oncologically appropriate. 26. However, serious perioperative morbidity and a mortality rate of up to 9% secondary to hepatic failure are recognized and are a function of the extent of resection and the presence of coexisting liver disease. 27. Possible complications include hemorrhage, bile leak, intra-abdominal sepsis, and cardiopulmonary dysfunction, and can occur in up to 21% of patients. 27. Of patients. 27. Nonetheless, studies have shown that overall quality of life can be improved by hepatic resection for malignant tumors. In 1999, Fong et al. Reviewed the outcome data for 1,001 patients who underwent liver resection for colorectal metastasis. The survival rate for these patients was 37% at 5 years and 22% at 10 years. The surgical mortality rate was low at less than 5%. A clinical risk score, CRS, was derived from these data to aid the appropriate selection of patients for liver resection. Clinical risk factors were defined as more than one tumor, carcinoembryonic antigen, CEA, more than 200 more than 200 nanograms per milliliter, metastasis more than 5 centimeters, node positive primary, and a disease-free interval less than 12 months. Paul et al. Concluded that patients with a CRS of 0 to 2 have a favorable outcome and hepatic resection should be considered. Patients with a CRS of 3 to 5 have a poorer prognosis, and liver resection should be considered in combination with neoadjuvant or adjuvant therapy. 29. See below. Minor hepatic resection involves no more than 2 conunode segments. Conal segments being removed, and major resection is defined as the removal of 3 or more segments. Minor laparoscopic liver resection, LLR, is now common practice, but remains in an assessment phase. 30. Certain outcomes, including post-operative complications and length of stay, are superior for laparoscopic procedures compared to open procedures, and no clinical outcomes are thought to be inferior. Unfortunately, the quality of studies consensus is based upon is generally low. Major LLR is not routinely performed laparoscopically. Available literature indicates that length of stay is superior to open procedures, and other outcomes are not inferior, although the quality of studies is generally low and further evidence is required. There is uncertainty of the sequence of surgery in synchronous OCRC. However, an international consensus panel, the management of a synchronous CRCLM, recommends that simultaneous surgery to the primary resection be performed in a minor resection is planned. If a major hepatic resection is required, then this should be performed as a separate procedure to the primary resection. Preoperative portal vein embolization, PVE, has been used to increase the feasibility of major hepatic resections by converting potentially unresectable lesions to resectable and reduce the risk of post-operative liver insufficiency or failure. PVE interrupts the portal vein flow to the region of the liver containing metastatic disease. This causes atrophy of the diseased liver and subsequent hypertrophy of healthy liver, i.e., the future liver remnant, via the release of hormones and growth factors. PVE is recommended when the future remnant liver is expected to be less or equal to 20% in normal liver or less or equal to 30% in diseased liver, 32. Pulmonary metastasectomy for colorectal metastasis is well established. And retrospective cohort studies have suggested that in highly selected patients, survival can be similar to patients undergoing hepatic resection or CRS 33. However, there is no randomized evidence to support this practice. The pulmonary metastasectomy in colorectal cancer, PALM-MCC, trial was designed to investigate whether active monitoring of colorectal lung metastasis results in similar OS to pulmonary metastasectomy. Unfortunately, the trial was stopped early due to poor recruitment and the statistical endpoints were not met. Long-term survival has also been recorded following resection of CRC, splenic, and adrenal metastasis, 34, though there are only scanty data to support surgery in this context. Systemic anti-cancer treatment. International guidelines state that in most cases of all CRC, systemic treatment remains the standard of care and should be considered as the initial treatment strategy regardless of local treatment modality. 131-35. See Table 1 and Figure 1. In patients with favorable surgical and oncological characteristics, the role of perioperative chemotherapy is less clear since the EPOC trial showed no difference in overall survival OS when perioperative chemotherapy was given to patients with initially resectable CRC liver metastasis. This randomized controlled phase 3 study recruited 362 patients from 78 international hospitals with up to 4 liver metastases and assigned them 1-to-1 to 12 weeks of FOLFOX, folinic acid, 5-fluorouracil, and oxaliplatin chemotherapy before and after surgery or surgery alone. Progression-free survival was increased by 8.1% at 3 years with the addition of chemotherapy, 36. Median OS was 61.3 months in the FOLFOX arm and 54.3 months in the surgery alone arm, though was not statistically significantly different. The new EPOC trial randomized patients with KRAS exon 2 wild-type resectable or suboptimally resectable CRC liver metastasis between perioperative chemotherapy with or without sig- uh, s- uh, just six see seta cetoximab 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 Cetuximab, a monoclonal antibody to EGFR with known benefit in KRAS wild-type advanced CRC 41, and found that progression-free survival was shortened with the addition of the antibody. However, in patients with anything less than excellent prognostic features, including all patients presenting with synchronous disease, perioperative chemotherapy is recommended. This is usually as FOLFOX without additional biological agents. In patients with poor prognostic features, FOLFOX or folfoxiri, folinic acid, 5-fluorouracil, oxaliplatin, and irinotecan, with or without bevacizumab, or are recommended. For patients with unfavorable prognostic features, despite the lack of randomized evidence, consensus guidelines suggest adjuvant chemotherapy is warranted in patients who have not had previous chemotherapy for metastatic disease. FOLFOX or CAPOX, Cap- capecitabine, capecitabine, and oxaliplatin are recommended unless adjuvant oxaliplatin was recently been administered for locally advanced disease. 1. Conversion chemotherapy is used to challenge patients. Mhm. To challenge patients with unresectable disease with the expectation that the disease may become operable. Currently, there do not exist good biomarkers to identify which patients with limited, inoperable metastatic disease will most benefit from this strategy. It is estimated that 20.5% of patients with unresectable disease may become eligible for surgery with modern chemotherapy 42. These patients can expect to have survival rates similar to patients who have initially resectable disease 43. All metastatic patients should be imaged after 2 months of treatment, and again after a further 4 months of systemic treatment to ensure that any window for local treatment is not missed. CELIM was a randomized phase 2 trial of 114 patients across 17 centers with non-resectable or more than 5 liver metastases. It compared situ, it compared cetuximab treatment with FOLFOX or FOLFIRI, folinic acid, 5-fluorouracil, and irinotecan. R0 margin negative resection was subsequently achieved in 38% and 30% of patients in the two respective arms. The Olivia trial compared bevacizumab with FOLFOX or FOLFOXORI in patients with unresectable liver metastasis. The overall resection rate was 61% and 45% with R0 resection rates of 49% and 23% in the two respective arms. There are to date insufficient clinical data on the role of systemic treatment in OCRC in non-hepatic sites to reliably inform treatment decisions. Stereotactic ablative body radiotherapy. SABR. SABR enables a very high dose of radiotherapy to be delivered with high precision to a target. It is delivered in either a single or small number, less than 8, of fractions, and planned to ensure a very steep dose fall or off from the target, Table 2. This enables a high biological equivalent dose, BED, to be delivered to the target. SABR is highly conformal to the target volume, which reduces normal tissue toxicity and therefore the risk of adverse effects. 46. It has many advantages over surgical resection, being non-invasive, delivered as an outpatient, and well tolerated in even very infirm patients. It is routinely used in patients who are medically inoperable. 48. In addition to treating lung and liver oligometastasis, SABR is used to treat bone, lymph node, and other soft tissue metastases. There is some evidence that metastases from CRC have a relatively radioresistant phenotype and may require dose escalation to achieve adequate local control, 50 to 53. However, several studies have demonstrated high rates of local control with SABR at current doses to OCRC. In 2018, Francese et al. Reviewed that outcomes of 437 oligometastases treated in 270 patients with colorectal cancer. 48.5% of metastases were pulmonary, 36.4% hepatic, 20.4% lymphatic, and the remaining 2.7% were adrenal, bone, or pancreatic. Local control rates of 95% at 1 year and 73% at 5 years were achieved. The OS rates were 88.5% and 37.2% at 1 and 5 years respectively. This study did not report treatment-related toxicity or patient-reported quality of life 54. A systematic review of 18 studies encompassing 656 patients with colorectal liver oligometastasis, 1-2 metastasis in almost all patients, published in 2018, demonstrated a local control rate of 67% and 59.3% at 1 and 2 years. The pooled OS rate was 67.18% and 56.5% at 1 year and 2 years respectively. Grade 1 to 2 liver toxicity was reported in 30.7% and grade 3 to 4 liver toxicity in 8.7%. 3 treatment-related deaths were reported, 0.004%, 55. In 2017, Kibila et al. Performed a systematic review into the treatment of CRC liver and lung oligometastasis with SABR. 15 studies were included, comprising 593 patients with 856 oligometastasis. The hepatic local control rates ranged from 50 to 100% and 32 to 91% at 1 and 2 years respectively. The pulmonary local control rates were 62 to 92% and 63 to and 53 to 93% at 1 and 2 years. In the lung SAPR studies, the rate of grade more than or equal to 3 toxicity was 0.7%. In the liver studies, the rate of grade more than or equal to 3 toxicities was 2.3%, 56. SABR, COMET, COMET, an international phase 2 study, was the first randomized trial to assess OS in patients with oligometastatic disease who received either SABR to all metastatic lesions or the palliative standard of care 57. 99 patients were enrolled at 10 centers. 33 were randomly assigned to the control group and 66 to the SABR group. 18 to 90 18/99 patients maybe, может быть, здесь 18 out of из 18 из 19 9. Может быть, да, тут идет речь про исследование. Возможно, это 18 из 19 9, из 99. 18 out of 99 patients had a primary colorectal cancer. Most patients had 1 to 3 metastases. Patients with breast and prostate cancer were overrepresented in the treatment group, accounting for 41% of patients receiving SABR, but only 21% of the control group. Nonetheless, the addition of SABR increased the 5-year OS from 17.7% to 42.3%, B equals 0.00658. At 4.5%, treatment-related mortality rate was observed in the SABR arm due to deaths from radiation pneumonitis. N equals 1. Pulmonary abscess N equals 1. And subdural hemorrhage after surgery to repair a SABR-related perforated gastric ulcer. N equals 1. Quality of life, QOL, was measured using a general tool of FACT G59, which includes 4 subscales: physical well-being, social family well-being, emotional well-being, and functional well-being. A 5-point decline in the total FACT G scale or a 2-point decline on a subscale is generally considered a clinically meaningful change. In the whole cohort, QOL declined, though minimally over time after randomization as a result of decline in physical and functional subscales. There were no reported declines in social and emotional subscales. Comparison between arms showed no differences in QOL between the SABR and SOC arms, SOC arms in total of or subscale scores. 60. Across all studies, patients with non-lung metastasis, tumors larger than 30 millimeters, and those heavily pretreated with systemic therapies generally have worse OS after SABR. A lower BD to the planned target volume is associated with higher rates of local failure after treatment with SABR 4649. There are technical challenges with delivering SABR, particularly due to organ motion and visualizing oligometastasis on cone beam, CT, CBCT scans prior and during treatment. With recent improvements in CBCT and the advent of the MR-Lineage, which enables superior soft tissue visualization and is able to track the target or a surrogate marker in real time during treatment, these difficulties may be reduced or overcome. SABR COMET hints at the promise of ablative radiotherapy in oligometastatic disease, but larger phase 3 trials are underway to establish its survival benefit, safety, and the limits of metastatic burden that warrant radical treatment. 62. Ideally, trials looking specifically at the use of SABR in the OCRC are required in order to establish the radiosensitivity of colorectal metastasis and the adjacent organs at risk.